Ashiqul Haque, and he's going to deliver a speech on diuretics in heart failure, friends or foe. Please come on dais and deliver your speech.
A very good afternoon, my senior sirs and colleagues. Today, my topic is diuretics in heart failure. Is it a friend or foe? We are lucky that we now know the term heart failure. In 17th century, it was only treated as dropsy, and the symptom was treated at that time. At that time, heart failure means only leg edema, shortness of breath, or cyanosis or JVP, and treatment was directed just for the symptoms. But treating a symptom won't treat the cause. Just like that, alleviating congestion does not cure the disease, just as alleviating fever does not cure the infection. Diuretics improve outcomes in heart failure. What is the level of evidence for that? The level of evidence is 0. In case of worsening heart failure, intravenous loop diuretics are recommended for all patients with acute heart failure admitted with signs symptoms of fluid overload to improve symptoms. The recommendation is class 1C. So the statement is that regardless of its magnitude, evidence from randomized control trial indicate that the short-term diuresis seen with any drug that inhibits renal tubular sodium reabsorption is not expected to exert beneficial effects on the clinical course of patients with heart failure following discharge from the hospital. In case of those acute heart failure study, which have shown where low dose and high dose diuretics were compared, although it has shown significant short-term effect on dyspnea, there was no effect on the length of stay. In case of chlorotic trial, adding oral hydrochlorothiazide to intravenous furosemide improved the diuretic response in patient admitted due to acute heart failure, irrespective of their eGFR. But the addition of it to a loop diuretic for 5 days, although it yields a modest diuretic effect, but there was no improvement in dyspnea, no improvement in 90 days heart failure with hospitalization, cardiovascular death, more worsening renal function, and more hypokalemia. Adding acetazolamide increased diuresis and natriuresis in the ADVOT trial, but when we see about the secondary endpoints, disconnecting between successful decongestion at the 3 days, there was no improvement in 90 days outcome. And there were marked changes in serum bicarbonate produced by acetazolamide, which might have led to inadvertent unblinding that influenced the physician assessment of physical signs. Similarly, Everest trial, where adding tolvaptan also did not have any effect on the outcome, cardiovascular death and heart failure hospitalization. In effect of necessitide in patients with acute decompensated heart failure also shown that there was significant short-term effect on dyspnea, but there was no long-term effect on the 30 days outcome. A short-term diuretic effect of any drug that promotes an increase in urinary volume or sodium excretion does not contribute meaningfully to changing the subsequent risk of major heart failure events. So we always want a better outcome. Better outcome means the patient feels better and patient lives longer. So why do diuretics not improve outcomes? I will call it a double whammy, a situation that is bad in 2 different ways. It is causing hypotension, rise in creatinine, hypokalemia, stimulation of the RAS system, rise of uric acids, and at the same time, it is not increasing the survival, it's increasing hospitalization, decreasing the quality of life, and increasing the symptoms, as we cannot up-titrate the GDMT. So are there any better options for that than diuretic therapy? Certainly there are. Several trials which have shown that if we introduce the drugs, even in hospital initiation, may improve the outcome in heart failure patients. So a soloist worsening heart failure trial where sotagliflozin was given in diabetic patients with acute decompensated heart failure have shown significant benefits. Similarly, impulse heart failure, also when patients treated with empagliflozin were more likely to experience a clinical benefit than those who received placebo. In case of pioneer trial, in switching from enalapril to sacubitril valsartan led to a sustained reduction in NT-proBNP. And in paradigm heart failure trial, there reduced loop diuretic use in patients taking ARNI compared with enalapril, which have also shown that benefit. In Victoria trial, vericiguat has shown improvement in cardiovascular death and fast heart failure hospitalization. And in case of strong heart failure trial, where rapid sequence of GDMT also led to a significant lower risk of death or hospitalization, improved patient-reported health status, improved clinical congestion, incremental lowering of NT-proBNP, substantially higher use and dosing of GDMT, and no excess risk of serious adverse events. So strong heart failure trial, we have seen that optimized neurohormonal blockade with the guideline-directed medical treatment have shown greater reduction, weight reduction, and dose is achieved with decongestion. Decongestion is an important goal of therapy in worsening heart failure and is associated with a lower risk of all-cause mortality and heart failure hospitalization. Decongestion may be achieved more efficiently with intensive up-titration of neurohormonal blockade as compared to diuretic-based usual care only. So here is the issue, there's still persistently unacceptable high residual risk of heart failure patients. And diuretic therapy, as it's seen here in the guideline, it shows that it was told that it improved exercise capacity and reduced hospitalization, but the level of evidence is class 1C, which was based on a meta-analysis, which was ultimately withdrawn in 2016, single meta-analysis. And in case of transform heart failure trial, where furosemide was compared with torsemide, they all did not reduce the primary outcome events. And diuretics ultimately also causes overactive bladder, and where frequency is increased to around 3 to 8 folds, and main reason for poor adherence and poor quality of life. So ultimately, the most effective approach to congestion is to prevent it with oral medical therapy. So at last, I will tell you that diuretics and heart failure, I will call it a necessary evil. So diuretics are good for losing salt and water. They have little proven effect on feeling better or living longer. If any diuretic worsens renal function associated with hypokalemia, jeopardizing the initiation and up-titration of chronic life-saving heart failure therapies.